Evaluation and treatment of cervicothoracic junction injuries. Cervicothoracic junction injuries are relatively rare, accounting from 2 to 9% of cervical injuries. But they can be a disproportionate cause of morbidity, as they are relatively hard to diagnose and may have a higher rate of associated neurological injuries. CT evaluation is necessary as plain films have a low diagnostic yield in this region of the spine. MRI is often used to better assess soft tissue components of the injury and especially the disco-ligamentous complex. It may also show a critical disc herniation, which may have implications if considering a closed reduction procedure. Biomechanically, the cervicothoracic junction is a transitional zone between the kyphotic thoracic spine and the lordotic cervical spine. There is also a transition from the relative rigidity of the thoracic spine supported by the ribs in the sternum to the mobile cervical spine. Anatomically, the pedicles and posterior elements also transition from cervical to thoracic morphology, and this change is relevant to posterior spinal instrumentation. In addition, the C7-T1 disc has a variable obliquity to the horizontal, which may be important as anterior-only spinal constructs do not adequately resist translational forces. Cervical spine injury classification classifies these injuries based on the morphology of the fracture, the integrity of the disco-ligamentous complex, and the neurological status of the patient. Based on injury morphology, no abnormality gets a score of 0, a compression deformity gets a score of 1, burst fractures get a score of 2, distraction injuries a score of 3, and translation or rotational injuries a score of 4. The disco-ligamentous complex, which is formed by the intervertebral disc, anterior and posterior longitudinal ligaments, interspinous ligaments, facet capsules, and ligamentum flavum, are the second component of this classification. An intact disco-ligamentous complex gets a score of 0, an indeterminate injury gets a score of 1, and disruption of the disco-ligamentous complex gets a score of 2. The integrity of the disco-ligamentous complex is considered indeterminate if it's only an isolated MRI signal change or an isolated widening of the spinous process. The neurological status of the patient is also scored with a score of 0 for an intact patient, score of 1 for root injury or radiculopathy, a score of 2 for complete cord injury, a score of 3, an additional score of 1 for continuous cord compression in the setting of neurological deficit. This classification system can also help making a decision of whether a patient needs surgery or not. Patients with scores of 1 to 3 points can be treated non-operatively. Patients with 4 points can be treated non-surgically or surgically according to the surgeon's preference and the patient's condition, and patients with score of 5 or more points are candidates for surgery with realignment and neurological decompression as needed and stabilization. The AO spine group has also proposed a classification based on morphological characteristics and mechanisms of injury as evident on imaging. This classification now also includes facet injuries and the neurological status of the patient, as well as other modifiers. Broadly, compression injuries are grouped into type A with an additional numeral indicating progressively severe injury. Similarly, type B injuries are tension band injuries and type C injuries are translational injuries. For example, type A injuries are compression injuries with A1 indicating a wedge compression of the vertebra, A2 indicating a split fracture, for example, a coronal split fracture, A3 indicating an incomplete burst fracture involving either the superior or the inferior end plate, and A4 are complete burst fractures involving both superior and inferior end plates. Similarly, the tension band injuries are classified as B1, B2, and B3 based on progressively worse imaging. Stands for bilateral injuries. Type C injuries include translation of the vertebral body in all three planes. Newer elements of the classification are type F injuries for facet injuries, and type N for neurological status, and type M for modifiers. Bracing may be considered for injuries which are not clearly unstable but have a potential for glacial instability. Bracing does not immobilize the spine and may only prevent supraphysiological movements. For the cervicothoracic region, a halo or a Minerva or SOMI type brace may be used. Surgery should be considered for unstable spinal injuries with instability defined as an inability of the spine to bear physiological loads without pain, deformity, or compression of neural elements, either acutely or glacially. Patients with overt instability, incomplete neurological injury, or continued spinal cord compression are good candidates for early surgical decompression. Patients with a SLIC score of more than 5 are also considered good candidates for early surgery. If using the AO classification, patients with type B2, B3, C, F3, and F4 injuries are also considered likely to need surgical stabilization. In addition, patients who have conditions that stiffen the cervical spine in the region of the cervicothoracic junction, such as ankylosing spondylitis, OPLL, DISH, or ossification of the ligamentum flavum, are also considered candidates for surgery. In the cervical spine, usually more than 11 degrees of kyphosis and more than 3.5 millimeters of translation is considered to be indicative of instability on upright films, but the cervicothoracic junction may not be well visualized in upright films, and these criteria can only be used in patients with appropriate anatomy conducive to evaluation on plain films. This algorithm shows how once an injury has been diagnosed, the next step is to judge for the stability of the injury. The SLIC and AO classifications may help in this determination. If the injury appears to be stable or equivocal, then a brace or a halo may be used and follow-up imaging may be utilized to assess glacial or delayed instability. A resolution of pain and stable appearance on follow-up imaging may lead to gradual de-escalation of care. For evidently unstable injuries, early surgery and stabilization are indicated with reduction and decompression as needed. This is a middle-aged gentleman who presented to us neurologically intact after a motorcycle accident. He had a C2 injury as well as an equivocal T1 fracture on his CT. Stir images showed increased stir signal in front of the C2 vertebra and also a subtly increased signal intensity in the T1 vertebral body. The patient was fitted with a brace, and a CT scan 4 weeks later clearly showed worsened appearance of the T1 fracture. Because of the patient's body habitus, it's clear that if a T1 corpectomy were to be considered, a manubrial window would be necessary. Once surgery has been decided upon, the approach is a second consideration. Anterior approaches are very familiar to spine surgeons. For the cervical spine, but in the cervicothoracic junction region, they may be limited by bony, vascular, visceral, and neural structures in this area. However, ventral approaches may be necessary to provide load bearing via the anterior column and for anterior decompression of the thecal sac and nerves. Those spine surgeons are familiar with the standard anteromedial approach to the cervical spine in patients with a favorable anatomy. The standard approach may not be sufficient for patients with short, thick necks or proximal thoracic kyphosis, and such patients may need a manubrial window if the procedure entails reaching down to T2 level, and if the procedure entails a need for reaching to T4, then a sternotomy may also be considered. For procedures below the T4 level, generally a thoracotomy is employed. Posterior approaches and their extensions are commonly performed and are often used as a standalone procedure for cervicothoracic junction trauma. The posterior approach allows decompression, realignment, and stabilization. Transpedicular vertebrectomy, costotransversectomy, and extracavitary approaches allow good ventral decompression of the thecal sac. Since the T1 and T2 nerves may contribute to the brachial plexus, these are usually preserved. Navigation systems allow placement of pedicle screws with a low risk of malposition, and the constructs can be extended superiorly and inferiorly as desired. However, in patients with 3-column injuries, it may be beneficial to provide anterior column support in addition to the posterior segmental fixation and stabilization. In summary, cardiothoracic junction injuries are uncommon but easily missed and have a high rate of associated neurological deficits. SLIC and AO classification are used to define the extent of injury and the potential for instability. MRI sequences may be useful in the assessment of ligamentous injury and critical disc herniation. If instability is thought to exist, early surgery is warranted. Early surgery may also improve neurological outcomes. While posterior approaches are commonly utilized, anterior approaches have a role in selected cases.